بسم الله الرحمن الرحيم. حان لي أشكرك جدا 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 يا دكتورة عزة على هذا الإثراء اللي يعني وسام على صدري. والحقيقة أمبري يعني بشكر جدا جدا دكتور أحمد على دعوتي إن أنا أشارك في هذا المؤتمر وعلى وجود قمة من قمم أمراض الدم، مش بس في مصر والعالم العربي والعالم عامة. القمم اللي قدامكم اللي كلكم عارفينهم واساميهم يعني بارزة جدا في كل الابحاث وكل المؤتمرات الدولية. النهارده يمكن هتكلم على hot topics on hemoglobinopathies, highlight on thalassemia. This is my disclosure. And the agenda including thalassemia. What about thalassemia in Egypt, new era in the management of thalassemia, and the conclusion. As you know, the pathophysiology of beta thalassemia depends on a balance between the beta and the alpha chain. Decrease in the alpha chain will have reduced level of the beta globin chain, excess free alpha globin chain, deposition in the membrane, hemolysis, at the end anemia. On the other hand, on the other side, there is absence of the beta globin chain, which is called beta zero thalassemia, leading to precipitation of erythroid precursor within the bone marrow, premature death of erythroid, reduced erythropoiesis, at the end anemia. Beta zero, beta plus, at the end there is anemia. The transfusion requirement is now used to distinguish the two major clinical phenotypes, non-transfusion dependent thalassemia and transfusion dependent thalassemia. Non-transfusion dependent thalassemia, the beta transfusion, beta thalassemia intermediate, mild moderate hemoglobin E beta thalassemia, hemoglobin H disease. Actually we have beta thalassemia intermediate, hemoglobin H disease is not so common in Egypt. This includes maybe transfusion seldom required, or on other hand, occasional transfusion required, for example during surgery, pregnancy, infection, or intermittent transfusion required when there is poor growth and development specific modalities. And on the other hand is the transfusion dependent thalassemia, which is very common in Egypt, which is beta thalassemia major, or hemoglobin parts hydrops, which actually uncommonly to be seen among patients or among a general population. What about the diagnosis and suggestive finding in beta thalassemia? We have got thalassemia minor. This is the thalassemia carrier, which usually clinically asymptomatic, but sometimes mild anemia is present and usually doesn't need any treatment except in other occasions. And to the other hand, or the last big hand, is the beta thalassemia major. And this should be suspected in an infant or child younger than 2 years of age with clinical screening, with clinical following severe microcytic anemia, which can occur early in life, mild jaundice, and hepatosplenomegaly. For the newborn screening, it is difficult to do, but by capillary electrophoresis or isoelectric focusing, we can diagnose thalassemia in the newborn. Or by molecular genetics, we can diagnose as well. We come to the intermediate, thalassemia intermediate. Should be suspected individuals who present at a later age with similar but milder clinical findings. Thalassemia intermediate do not require, and I'm saying again, do not require regular treatment with blood transfusion. What about the treatment, usual treatment of beta thalassemia? Of course, blood transfusion. This is the mainstay standard of transfusion-dependent patients. Blood transfusion, accumulation of iron, then we have to have iron chelation therapy. This is the standard of care of treatment of iron overload due transfusion therapy, or in thalassemia intermediate, though there is no blood transfusion, but there is increased absorption of iron, and the patient may need as well for iron chelation therapy. Hematopoietic stem cell transplantation, the only definitive cure we have in our country now. Splenectomy come back to splenectomy now, or we are going to have splenectomy, which is removal of the spleen, should be restricted to certain patients, as we are going to see now. Transfusion-dependent beta thalassemia, thalassemia major, recommended treatment for beta thalassemia is regular blood transfusion every 2 to 5 weeks to maintain hemoglobin level above 9 to 10.5 grams per deciliter. Iron creatine therapy, of course. This regimen minimizes iron loading and suppresses bone marrow expansion. Transfusion requirement of unsplenectomized patients are 30% higher than requirement of a splenectomized patient. The presence of big spleen increases the burden of blood transfusion. But there is criteria for transfusion, laboratory criteria and clinical criteria. For laboratory criteria, if hemoglobin level is below than 7 grams per deciliter on 2 occasions, 2 weeks apart. On the other hand, hemoglobin level is more than 7 grams, but I have to give blood transfusion. If there is facial changes, more growth, fractures, clinically significant extramedullary hematopoiesis. And this is transfusion program to maintain the transfusion hemoglobin level, 9.5 or 10.5 grams per deciliter in thalassemia major, pre-transfusion hemoglobin level of 110 or 120 for patient with heart disease or clinically significant extramedullary hematopoiesis. Hematopoietic stem cell transplantation, actually, this is the only curative treatment which we have here in Egypt. It has got advantage, but it has certain limitation. For the advantage, currently the only definitive cure for beta thalassemia major. Long-term outcome is excellent, with more than 90% survival, should be offered for beta thalassemia major patient at an early age. Myeloablative conditioning regimen are required and should always be used. On the other hand, there is some limitation or disadvantage of this procedure. More than 50% of patients cannot receive hematopoietic stem cell transplantation due to lack of suitable donors. Know that it should be fully compatible with the donor and the recipient. And usually it is one of the siblings, mother and father, if they are related or there is consanguinity, we may have one of the parents. Less than 10% of eligible patients are able to access this therapy. Inadequate transplantation service and high cost limit, this is the cause. Hematopoietic stem cell transplant risks are related to intensive myeloablative conditioning regimen. This ablative regimen may affect the productivity of the patient later on. Stem cell transplant is the curative treatment for thalassemia. Only 30% has got, as I said, and we come to splenectomy. Splenectomy may be indicated for thalassemia major patient with increased transfusion burden. However, splenectomy induces a hypercoagulable state and increase the risk of thrombosis. There is leukocytosis and there is thrombocytosis, and both can be a good triggering for thrombosis. Splenectomy increases the risk of infection, pulmonary hypertension, and iron overload. As a result, splenectomy is carried out only in the most serious cases. We come to the new, it's not so new, but it is the early or the recent developed in the world, which is gene therapy approach. Upon first isolation of the hematopoietic stem cell of the patient and progenitor cells, then exogenous beta globin gene, as you see, are then incorporated into the host genome by lentivirus beta globin plus. And after full or partial myeloablation, these genetically modified autologous hematopoietic stem cells are then returned to the patient, where they repopulate in the hematopoietic compartment after having the new gene of thalassemia. For gene therapy to be successful, engraftment and gene transfer should occur at high efficiency and lead to high levels of gene expression with minimal to no risk of insertional mutagenesis. Another mode of gene therapy in the use of CRISPR-Cas9. This is a clinical trial, but now it is used. It is clinical trial where they took the stem cells of the patient and then isolate CD34, incorporate CRISPR-Cas9 delivered via the electroporation to the stem cells of the patient, then incubated CRISPR-Cas9 after stem cell cytotox, cryopreserved, tested, and released to the patient. We have to do ablation of the marrow of the patient and then give him the newly incorporated gene for thalassemia into this patient after full ablation of the marrow of the patient, and we have to go follow up for this patient. What about thalassemia in Egypt? In Egypt, it is very common, described very early, since 1944, in our hospital, Abu Rish Hospital, our dear Professor late Diwani. The carrier rate is very high, 5.3 to more than 9%. The big study, almost of the coronaries in Abu Rish Hospital. We have got a very high number of thalassemia patients coming out and born in Egypt. That's why you have to do prevention of thalassemia in Egypt. This is showing you the registered case of homozygous beta thalassemia in big centers of Egypt, Cairo University, Mansoura, and Shams, all the universities here, Tanta, all the universities are here presenting the number which is registered. Maybe there are more and more which are not registered. But there is some concern in the treatment of thalassemia in Egypt. For low pre-transfusion hemoglobin was detected among the Egyptian thalassemia patients. The average is 5.7 or 6 grams per deciliter, which is very low for thalassemia major. Immunization and autoimmunization are common among multi-transfused thalassemia patients in Egypt. Immunization mounts up to 18%, autoimmunization up to 16.5%, and this sometimes be fatal for the patient that I couldn't give him blood transfusion. Every blood goes reaction. And actually we lost patients that died without having blood transfusion because no transfusion is compatible with their own blood, but by hemoglobin and red cell exchange, we can do that. Non-transferrin bond iron and iron overload. From frequent blood transfusion, there is accumulation of iron or ferritin, which can go to every body and every system in the body. There is multiple endocrine abnormalities due to iron overload, heart failure, cirrhosis, liver cancer, growth retardation. Iron accumulation is toxic to many tissues, as you see. And this is magnetic resonance in thalassemia, which is important really. We have to do it for follow-up to our patients, monitoring the iron overload by MRI in the liver, as you see in the left side, and in the heart, in order to increase the chelation therapy and to take care of the follow-up of this patient. So MRI to the heart and liver is very important for the follow-up of our patient and for monitoring the iron overload for this patient. This is 2 star for the heart and R2 for the liver. Hepatitis C virus in Egyptian thalassemics was very, very high. It mounts up to 70%, 74%, they're very high. But now, after the presidential study and prevention of hepatitis C, I think that hepatitis C actually remarkably now get decreased than before. Screening for thalassemia in Egypt, which is really was very successful and very beneficial for our thalassemia patient and for every patient who has need for frequent blood transfusion. Hepatitis C for the patient not only affecting the patient, but can affect the family. And we did this study and found that the mother is the one which is easily and can be taken hepatitis C from her kid. The prevention program, basic elements, information, carrier screening, genetic counseling, and prenatal diagnosis should be available and should be for every family who are carrier for the thalassemia or who have kids with thalassemia before. But actually, we should give good information for our community in order to do very well, especially if there is a previous sibling, to go away coming from, not only from marriage relatives, but as thalassemia is very common in Egypt, carrier rate, even not relatives, they can have thalassemia patient. What we need to prevent thalassemia, improving public awareness, screening for secondary school students, not when the patient is going to marry. To marry, okay, but it should be given before that. When the patient is coming to you to marry, which is preparing everything, when you stay there, don't marry both, they will say bye-bye. They will not do it. Well-equipped central lab for prenatal diagnosis should be done. There is new era in the management of thalassemia. This is new era for what? For the study or for treatment of the impaired alpha to beta globin ratio. This by gene therapy, gene editing, as I showed you. And the most important, the ineffective erythropoiesis, which actually is the cause of anemia and cause of the many complications, as you see down, diabetes, leg ulcers, bone deformities, hepatomegaly, and even cancer. All this due to blood, the patient receiving blood, there's low hemoglobin, there's increased iron overload. All this can got these complications. A new drug, which is lebrozil, and you heard about, most of the patients are coming to us, what about the new treatment? أخبار الدواء الجديد إيه؟ دايما بيسألونا عليه, which is lebrozil or luspatercept, is a first-in-class erythroid maturation agent. There is block in the maturation of erythrocytes in the bone marrow. It is believed to regulate late-stage red blood cell maturation. Red cell maturation meaning we have more hemoglobin and we have to go away from the complications of anemia, blood transfusion, iron overload, and so on. Lebrozil increases hemoglobin levels and significantly reduces the RBC transfusion burden in patients with beta thalassemia associated anemia. And this is showing you the reduction in transfusion burden in transfusion-dependent patients who received luspatercept or lebrozil. This is decreased the amount of blood received by the patient more than 20 units in 24 weeks. Decrease the amount, meaning decrease in the iron overload and improvement of the general life of the patient. As you see here, quality of life changes during receiving this treatment, during the study of this management of this treatment, luspatercept. They did, and they found that there's improvement in all aspects of life of patients receiving this treatment. Luspatercept leads to reduction in serum ferritin and the other markers of iron overload in patients with both transfusion-dependent and non-transfusion-dependent treatment disease. By reducing RBCs, luspatercept reduces the amount of iron entering the body, will decrease the amount and repeatedly and the frequency of blood transfusion. It's generally safe and well tolerated. So, the conclusion, high prevalence of thalassemia in Egypt, calling for urgent prevention program. A presidential initiative for premarital screening is starting a hope for prevention of the disease in Egypt. Screening for thalassemia with the vaccination program, meaning early, after the age of 1 year, may give a better outcome. The patient will be aware that their kid are carrier or not. A presidential initiative for blood donation should start after the successful plasma program established by the Ministry of Health to cope with the disease needs, because we have lack of blood, of sufficient blood for most of the patients. Awareness for thalassemia disease through mass media should be started and supported by the Ministry of Health. Decrease in the incidence of hepatitis C in thalassemia patients and blood donors after successful screening and treatment programs of the Ministry of Health in Egypt. This is a reality. The novel medical treatment of thalassemia decrease the transfusion burden, iron overload, and chelation, thus improving the quality of life of this patient. It is cost effective because it is very, very expensive. And this showing you one of our patients who is thalassemia intermedia, but before marriage, we did examine the blood of the one she's going to marry, and who was not a carrier at all, and she has got 2 kids who are only thalassemia carrier. And this is showing you the children in 2002 and 1990, before the proper treatment of thalassemia in Egypt. The one on the left, the same age as the one on the right, with huge spleen, stunted growth, classical facial faces. On the right side, the same age, with a better condition. And this is one thalassemia looking for your good hands for a better life. And thank you all for attending.